example,
Yes.
when it comes to the epinephrine, we had said that it's considered a hormone instead of a neurotransmitter because once it goes through the adrenal medulla, it doesn't have like a postganglionic neuron, right? Like there's not another neuron to go into, right?
The adrenal medulla simply releases it
to
the blood. Okay.
And then it just travels to other places. Okay, thank you.
In the case of the nervous system, it is considered a neurotransmitter.
Okay, thank you. Oh, okay. Yeah.
Okay, it is 11 a.m., so we are ready to start. And well, if you have any difficulty during the lecture, okay, write it in the chat. Okay, try now to unmute your microphone so we don't have any feedback, sound or noises. And then you're gonna have access to the recording. We are recording this, okay, in the same place where we created that room. Okay, when you come here, let me see if we can see it now. You should have the recording somewhere. Right now, I don't see anything because there is nothing, but you should find the recording there. And maybe I can allow the download just in case you need it to have it offline or something. So today we are going to be talking about calcium metabolism. Okay, it's a complex topic. Okay, interpreting the calcium problems is not easy. Okay, something that we have to consider many things together. Okay, to have an accurate idea of what's going on in the patient. Okay, we have to talk about parathyroid hormone, but vitamin D is extremely important in the calcium metabolism. So we have to try to understand how vitamin D and PTH interact in order to regulate the metabolism of calcium, the blood calcium levels. Okay, we have to remember that calcium is one of the most abundant minerals in the body. However, the only calcium that is important for the metabolic functions of the body is the free calcium. Okay, not the calcium that is bound to phosphate or to other or to other elements. Okay, so we are going to try to understand this process. And first of all, let's talk about vitamin D, which is a hormone. Okay, many years ago or some years ago, it was considered simply a vitamin. Okay, a necessary essential nutrient, but we didn't know about the many functions that vitamin D has, not only for calcium metabolism, also to protect the body against different conditions for the immune system, reproductive function, etc. So it's a hormone that is made in the skin. Okay, the skin has some endocrine functions. This is one of them. Okay, we need sunlight exposure to fuel the process of vitamin D synthesis. We make it in the skin as vitamin D3, which is a precursor of the actual active form of the hormone. Okay, we also can ingest vitamin D from supplements or from plants, for example, but that is in the form of vitamin D2. Okay, these are pre-hormones, both of them, and we need to convert these compounds into the active form to be able to use it. The first step is the hydroxylation in the liver. This is called 25-hydroxylation. And then we have another step that occurs in the kidney. Okay, notice that now we are adding another hydroxyl group, 1-hydroxylation, to make 1,25-dihydroxy vitamin D. Okay, the first compound is 25-hydroxy, okay, or 25-OH. And then the active form is 125 dihydroxy vitamin D. Okay, the other the 25 hydroxy or the vitamin D3, D2, they are inactive. Now, one of the main functions, talking about the calcium metabolism, is to increase the amount of calcium. Notice that this is the ionic form of calcium, and also phosphate in the serum, increasing the absorption of calcium and phosphate, both of them, from the intestines, and also the resorption of calcium and phosphate from the bone. Those are the main functions of vitamin D. Then we need to compare this to the function of PTH. Okay, we are going to see some diagrams that will help us see this better. Okay, when calcium levels, for example, drop, okay, we are going to have immediately the release of parathyroid hormone from the parathyroid glands, and that PTH will stimulate this second step here. Okay, there is an enzyme in the kidney that is called alpha-1 hydroxylase that is stimulated by PTH to produce the active form of the vitamin D. Okay, any moment that we have hypocalcemia or hypophosphatemia, okay, that's gonna be stimulated. Okay, and then the active form of the hormone is the one that is gonna make the negative feedback on the alpha-1 hydroxylase. It's gonna lower the activity of this enzyme. So here we have some diagrams that place this in, so you have a visual understanding of this. Notice that vitamin D3 is made from cholesterol, cholecalciferol, okay, while the vitamin D2, we obtain it from dietary supplements, from food, in the form of ergocalciferol. Okay, animals have cholesterol, plants have ergosterols. Okay, so it's a similar form, but from different molecules. The first enzyme that participates there is 25 hydroxylase in the liver, making the 25 vitamin D, hydroxy D. And then the second step, the alpha-1 hydroxylase in the liver, in the kidney. So we obtain this molecule with 2 hydroxyl groups, 125 dihydroxy D, also known as calcitriol. Okay, calcitriol is the active form. And then we are going to have the biological actions once this vitamin binds to receptors and does the things that it does. Now, here we have another diagram. This is more detailed. Okay, we here have the vitamin D pathway. Okay, the following diagram is going to show exactly this, but we are going to add the PTH pathway. Okay, so we can compare the actions. Okay, we have here exactly the same. We have the vitamin D3 converted to 25 hydroxy in the liver and converted to 125 dihydroxy in the kidney. Now, what are the actions of vitamin D? We are going to see that it will activate the release of calcium and phosphate from the bone, increasing the calcium and phosphate levels. Okay, it's gonna, in the small intestine, is gonna increase the absorption of calcium and phosphate too. It doesn't mention, but also phosphate. Okay, and what else? Well, we have here the kidney. Okay, notice that in the kidney, at the same time, what is happening? We have increased calcitriol, vitamin D secretion. Okay, the kidney is also decreasing the excretion of calcium, so increasing or retaining calcium in the blood, but eliminating phosphate. Okay, the final thing that happens here is that we are going to have calcium increase, but phosphate will decrease. Why is that necessary? Because if we have the same amount of calcium and phosphate in the serum, they will bind to each other. And we don't need calcium phosphate, we need calcium, free calcium. Okay, now, what happens with PTH? What is the role of PTH in all this? That's what we have here. Notice that we have exactly the same for vitamin D, but we are adding this PTH pathway. These are different stimuli, low calcium, low magnesium. Okay, these are two stimuli that stimulate the chief cells of the parathyroid gland to increase parathyroid hormone secretion. Okay, notice that PTH will stimulate the kidney to increase the vitamin D3, the calcitriol secretion. Okay, that will perform these actions that we mentioned before. It also acts on the bone, okay, to stimulate the release of calcium and phosphate. Okay, and this action here is not very important. It's not something, the gut is not very dependent on PTH for increasing the calcium absorption. This function here is more of vitamin D than of PTH. Okay, but the final thing that will happen is increase serum calcium, the free calcium, ionized calcium. Now, one important thing that we need to know is that magnesium is a mineral that is necessary for the parathyroid glands to produce PTH. Okay, so imagine someone who doesn't make PTH. Okay, there is a dysfunction, and we have that person has low calcium, and we see that despite having low calcium levels, they are not producing PTH. Well, maybe is because they lack magnesium. So in that case, treatment with magnesium will allow the parathyroid glands to produce the PTH. Okay, so magnesium levels should be considered when we see that patients don't respond properly to the homeostatic mechanisms. Okay, so now we can take a look at the diseases, okay, that may occur because of excessive production or decreased production of parathyroid hormone, okay, or also considering the role of vitamin D in all these processes. Okay, we call hyperparathyroidism to a condition, any condition in which there is an excessive production of PTH, okay, that typically leads to hypercalcemia. Okay, there are different risk factors. For example, someone may have a prolonged calcium or vitamin D deficiency. Okay, if we don't have, we have nutritional disorders or absorption disorders and calcium levels are low, they are going to produce more PTH. Or if we don't have vitamin D, okay, despite having low calcium, vitamin D, it doesn't let us absorb calcium from the gut, doesn't let us reabsorb the calcium from the kidney. So there is going to be a chronic hypocalcemia. And this lack of vitamin D is going to produce hypocalcemia and is going to lead to excessive PTH. Okay, menopause, radiation to the neck, lithium, okay, different things may produce hyperparathyroidism. Now, how this works? As in many other conditions, we classify this disorder, the excessive PTH, into primary and secondary and even tertiary causes. Notice that here we are going to have a classification that is different, totally different to the disorders that depend on the hypothalamus. Okay, when you study the regulation, remember we had the hormonal regulation and also the humoral. Okay, humoral regulation of the hormone levels depends on the serum or blood levels of the hormone or some metabolites like glucose or calcium. Okay, so we are going to see the differences between what we consider primary hyperthyroidism, for example, or secondary hyperthyroidism or tertiary hyperthyroidism with what we consider primary, secondary, and tertiary hyperparathyroidism. Okay, what are causes of primary hyperparathyroidism? This is not very different from what we consider in other cases. Okay, primary is when there is a problem in the gland itself. For example, the parathyroid gland may produce excess hormones because there is an adenoma or because there is hyperplasia or carcinoma. That's not frequent. Okay, in this case, let me use the pen. Okay, the gland, this is starts producing PTH. And the PTH, when it's elevated, produces an increase in calcium levels, free calcium. Okay, so the first thing that happens is increased PTH, and the second thing that happens is increased calcium, PTH dependent. Okay, and what happens that this elevated calcium fails to inhibit PTH. Why? Because there is a problem in the gland. Okay, someone has an adenoma or other conditions. Well, these cells are abnormal and they don't respond to the increased calcium, so they continue producing PTH. Now, what is secondary? Okay, remember, we don't have here a pituitary hormone. Okay, so we can compare pituitary hormones with the hormones of the gland. Okay, this is secondary because PTH increases, there is an increase in PTH that occurs as a second step. Why? Because calcium levels were low. Okay, so notice that here, the first thing that happens is low calcium, and that produces an increase in PTH as a response. Okay, it's a compensatory response. That's why we call it secondary hyperparathyroidism, in contrast to primary hyperparathyroidism. Okay, this, for example, is due to kidney disease. Someone with kidney failure, the kidneys simply don't work. PTH tries to stimulate them. Vitamin D may try to stimulate them, but they don't retain the calcium. Or they are not activating vitamin D, because when someone has kidney failure, okay, the liver makes 25 hydroxy vitamin D, but the kidneys don't activate it because they simply don't work. Okay, and this hypocalcemia will stimulate the parathyroid glands to increase PTH. Now, there is a tertiary that has nothing to do with the hypothalamus. Okay, and this is a condition that appears in people that have been many years with chronic kidney disease and probably are on dialysis. Okay, dialysis patients, or after many years of secondary hyperthyroidism, there is a moment when the PTH and the calcium levels lose totally their relationship. They are totally unrelated. The gland becomes autonomous. So there is no explanation for anything that happens there. In that moment, we call it tertiary. Okay, it's more a clinical definition than a physiological definition. Now, what are the clinical features? Well, the most important thing and the factor that determines the signs and symptoms are the levels of calcium and phosphate. Okay, elevated calcium, okay, is the one that actually produces the symptoms. Okay, this is something that can be asymptomatic for a long time. Okay, mostly if the calcium levels increase slowly. Remember, the body adapts to this. But typically, they have these classic signs and symptoms: kidney stones, bone pain, abdominal pain, because there is constipation, there is low motility, and there can be some psychological issues, okay, mood disorders or depression. You have this classic mnemonic of stones, bones, groans, and psychic moans that tend to appear together in vignettes. Okay. And well, the clinical features also will depend on if it's a primary, secondary, or tertiary. Okay. For example, in the primary, patients typically don't have any systemic disorder like chronic kidney disease. Okay, they may have an adenoma, so the only finding may be a discomfort in the throat or a mass that we palpate. Okay, so they are going to have increased PTH, increased calcium, and low phosphate. These are the typical findings: PTH elevated, elevated calcium, and phosphate is low. What about the secondary? This is the typical patient with chronic kidney disease, so may have the history of chronic kidney disease, or maybe there is no history, but we find that the patient has a glomerular filtration rate, maybe of 20 or 15, okay? The very low GFR, elevated creatinine, okay? There is a failure to activate vitamin D. So we don't absorb calcium, okay? But notice here that the calcium levels may be low or normal. Okay, and there is going to be hyperphosphatemia. Okay, so we are going to have low calcium in the secondary or normal. Okay. Okay, what about the phosphate, elevated phosphate? And that will lead to a secondary increase in PTH. You can put together the typical findings: elevated phosphate, elevated PTH, calcium low or normal. Compare with this, which phosphate is low and calcium is elevated. But in both cases, PTH is going to be elevated. And what about the tertiary? Now, that's difficult to interpret. The only thing we know is that the patient is on dialysis or has been many years with chronic kidney disease. Notice increased PTH, calcium, phosphate. Okay, everything is elevated, but there is no explanation for anything. So it's more a clinical diagnosis. Now, besides chronic kidney disease, this secondary hyperthyroidism may be due to low calcium or low vitamin D intake. Okay, how we know? If they give us only the blood tests, if this secondary kidney disease, hyperparathyroidism is due to chronic kidney disease or low vitamin D, well, there is a test that we can do, and that is the 25-hydroxy vitamin D. Remember, this is the one that the liver makes. Okay, if someone has a kidney problem, this should be normal. Okay, but if someone has a nutritional problem, this should be low, because this is the one that we make in the liver from the diet, from supplements, okay, the one that is associated with the vitamin D that we make or take. Okay, so this should be low when there is a nutritional problem and normal when there is a kidney problem, the one that the liver makes. Now, there we have a diagram or table, no, that tries to put together some important things. So you have them in a place. Okay, there are different causes of hypercalcemia. Because remember, probably the finding that we are going to have is elevated calcium in an asymptomatic patient or a patient with unspecific clinical findings. So what is our differential diagnosis for hypercalcemia? Well, the most common causes are, okay, primary hyperparathyroidism. Primary hyperparathyroidism is here. So you know what is that, PHPT. And malignancy. These are the main things that we have to rule out. 90% of the cases. Then we have in the other percentage, the other 10% is a less common cause, not very common at all. There is a condition called familial hypocalceuric hypercalcemia. Okay, this looks similar when you do blood tests, looks similar to primary hyperparathyroidism. However, when we have hypercalcemia, for any of these reasons, the calcium in the urine should be elevated. Okay, because we are eliminating the excess. And these people have a normal calcium in the urine or no calcium at all. Okay, it's a benign disorder. It doesn't create any problem. They are not going to have kidney stones. They simply have more calcium than everybody else in the blood. Okay, there is it shouldn't be even considered a disorder because this doesn't produce any complications. And of course, we have to rule out medications. Thiazides reduce the urinary calcium excretion. Lithium decreases the sensitivity of the parathyroid gland to calcium. So these medications, for example, thiazides, okay, and this gives you a very good information for pharmacology medicine. Okay, if someone has hypercalcemia, don't give thiazides. If someone has kidney stones and they don't have any hypercalcemia, we can give thiazides to reduce the urinary calcium excretion. That's one example of how this is asked. So there you have some causes, no, in this table. We have the primary hyperparathyroidism, some, remember the men syndromes, okay, men, for example, type 1 that has a parathyroid hyperplasia. Okay, there are familial hypocalceuric hypercalcemia, tertiary and secondary hyperparathyroidism, tertiary hyperparathyroidism. And what about non-parathyroid mediated? Well, we have the hypercalcemia of malignancy, can be due to an increased production of PTH-RP, PTH-related peptide, paraneoplastic syndromes. Okay, calcium may increase also because of increased activation of vitamin D, extrarenal. Okay, this may happen not only in malignancy, this may happen also in sarcoidosis. Okay, people with sarcoidosis, the macrophages in the patients with sarcoidosis have excessive activity of the alpha-1 hydroxylase. That's why they tend to have elevated levels of calcitriol and elevated calcium in the blood. Okay, calcium may increase because of the osteolysis in the bone metastasis or inflammatory process in the bone, excess vitamin D, like some chronic granulomatous disease. There you have, sarcoidosis is here, okay, granulomatous disease. Okay, the same mechanism I was mentioning. There you have medications, thiazides, as we mentioned, lithium, and there you have more, okay? And some other conditions that may increase the calcium are hyperthyroidism, acromegaly, pheochromocytoma, adrenal insufficiency, immobilization, okay? And milk alkali syndrome. Milk alkali syndrome is something that was very frequent before the antacids appeared in the market, okay, before PPIs. The only treatment that people had for GERD and heartburn, okay, was milk and sodium bicarbonate, baking soda. Okay, baking soda. So they used to have a lot of metabolic alkalosis as a result of taking too much baking soda. And if they used to take milk, a lot of milk, they would have some mild hypercalcemia as well. That is not very frequent nowadays, unless patients get crazy taking calcium supplements. Okay, but if they take what is indicated, they are not supposed to have any of this. Now, the signs and symptoms, we already mentioned these classic signs and symptoms that appear in all of these mnemonics, okay, bone pain, kidney stones, okay, osteopenia, osteoporosis, okay, depression, okay, constipation, producing pain, abdominal pain. Polyuria, now put this together with what we studied in the first lecture, hypercalcemia producing a nephrogenic diabetes insipidus. And they may have other very non-specific findings, memory loss, myalgia, paresthesia, okay, poor sleep, fatigue, anxiety, muscle cramps. Okay, you have exactly the same here, but organized by system. Okay, and GI. Notice that pancreatitis, the calcium has to be really high to produce pancreatitis. Okay, peptic ulcer, because also calcium stimulates the production of acid from the stomach. Okay, they are going to have some cardiovascular. Notice that hypercalcemia shortens the QT. Hypocalcemia lengthens the QT. You have some other EKG abnormalities. Okay, may mimic myocardial infarction. Okay, may produce arrhythmias, hypertension. And there you have the diabetes insipidus and may even trigger acute kidney injury. But this depends also always on the level of calcium. Now, there is something that we have to also mention, okay, and it's the relationship between pH and calcium levels. Okay, what happens when there is a acidosis, for example, versus alkalosis. Okay, when there is alkalosis, okay, the free calcium, let's put ionized calcium, okay, tends to bind to albumin. Okay, on the contrary, when there is acidosis, the free calcium tends to move away from albumin. So albumin releases the calcium. So acidosis tends to produce hypercalcemia, while alkalosis tends to produce hypocalcemia. Okay, that is something important to have in mind. Let's say you have a patient that has a panic attack, is hyperventilating, and you do blood tests and you find hypocalcemia. That's totally normal. We don't have to give any calcium to this patient. Just when they come down and they start breathing normally, okay, the same with a hypercalcemia in the setting of acidosis. We have to correct the acidosis, okay, and then the calcium will normalize. And here we have the different causes, okay, different causes of hypercalcemia in this diagram. Okay, because remember, one of the two most common causes of hypercalcemia are the primary hyperparathyroidism, okay, and hypercalcemia of malignancy. Okay, when someone has a hypercalcemia of malignancy, the calcium levels tend to be really, really elevated. Okay, if you find a patient with the calcium in 9, in 10, there's a mild hypercalcemia, that is likely PTH related. That is likely some of these mechanisms that we mentioned before. Okay, the calcium is going to be really, really high in the 12, 13, 14, more symptoms, more electrocardiographic findings. And typically, this is produced by PTHRP, parathyroid hormone related peptide or related protein. And we are going to find an elevation in this protein. When you order intact PTH, that is going to be low. Okay, so calcium increases because of a response to this peptide. Also, when people have metastasis in the bone, and remember what we mentioned, some tumors, lymphomas, ovarian cancers activate vitamin D. Okay, in some cases, maybe PTH and not PTHRP. Okay, parathyroid cancer, small cell lung carcinoma may produce PTH. But there you have a diagram for you to see, for example, PTHRP related more than 75% of the cases. Metastasis is what follows. Okay, overproduction of vitamin D, a smaller proportion, and a tiny, tiny proportion PTH related, ectopic PTH production. Okay, in most cases, the intact PTH is going to be low. So we are going to have an increase in PTHRP. And this is going to serve you a lot, okay, to interpret blood tests. Okay, notice, and this is something that we were explaining before, how to use the lab findings. Okay, notice that in primary, And in tertiary hyperparathyroidism, in both calcium is going to be elevated. In the secondary, low or normal. It's the only one that has low calcium. By definition, hyperparathyroidism is elevated PTH. Notice that in the tertiary is very elevated in the secondary, and could be normal in the primary. Okay, why normal? Because it depends on the cause. If we have an adenoma or a carcinoma that are producing PTH, leading to increasing calcium, the negative feedback doesn't work because adenomas and carcinomas don't respond to negative feedback. So PTH is going to stay high. However, if we have a hyperplasia, which is simply an increase in the number of cells producing PTH and leading to elevated calcium, that hyperplasia does respond to negative feedback. And the PTH will normalize. It's not gonna it's not gonna be low. If it is low, that is not a problem, that is physiologic. But if it stays in normal levels, despite the high calcium, there is a problem, and it's the hyperplasia. They are responding to feedback, but they are too many. So the levels are normal, but not normal. In a normal condition, they should be low. What about vitamin D? Notice that in the secondary and in the tertiary, they are low. Why? Because this is a kidney problem. Or is a vitamin D deficiency, nutritional. Okay, so it has to be low. In the case of the secondary, vitamin D is in the secondary. Vitamin D deficiency. So in both cases, vitamin D is low. Vitamin D is gonna be elevated, okay, in the primary, because remember here the kidney is working fine. Okay, there is no problem in the kidney, in the primary. There is an adenoma in the parathyroid. So the elevated PTH is gonna stimulate vitamin D activation. What about the phosphate? For the same reason, the kidneys are perfectly eliminating phosphate. Okay. Now, the other two, secondary and tertiary, remember the kidney is not working here. So phosphate is going to be elevated, but maybe low. Okay, why maybe phosphate low? Because maybe here the problem is vitamin D deficiency. Okay, so PTH is going to do its action of making the kidney eliminate phosphate. So depending on the cause, vitamin D or kidney can be elevated or low. Okay, it's complicated. There are many things to have in mind. But with time, okay, you're gonna get this. In the notes, in this slide, you have more information. So if you wanna see examples of this. And here we have what happens when there is a vitamin D deficiency. Okay, vitamin D deficiency, well, it depends on if this is occurring in adults or in kids. Okay, but we are gonna develop a condition that is similar. Okay, can be called osteomalacia or rickets in kids, only kids. Osteomalacia can happen in anybody. The kid can have rickets and osteomalacia. Okay, what is the pathophysiology of this condition? Well, as a result of the deficiency in vitamin D, there is going to be an impaired mineralization of the bone matrix. Okay. The bones are going to be soft. In fact, the Greek word malakos from where Malaysia comes from, means soft. Okay. So we don't mineralize the bone. It's gonna be like almost a very, very weak bone. Okay, deficient or defective mineralization of the osteoid. Okay, and rickets, the difference is that there is a defective mineralization of the cartilage in the growth plate. Why doesn't happen in adults? Because we don't have a growth plate. Okay, if we had, we would have also rickets. Okay, but children can have both osteomalacia happening in the growth plate, rickets in the growth plate, and osteomalacia happening in the bone, okay, in the bone itself. Besides vitamin D deficiency, there are other conditions, for example, primary hypophosphatemia, but that is not as common as the vitamin D deficiency. Okay, nutritional disorder, a poor dietary intake, lack of sun exposure, okay, will lead to malabsorption, malabsorptive disorders. We don't absorb the vitamin D. Remember, this is a fat-soluble vitamin, so having fat malabsorption will make us eliminate and not absorb not only this, all the vitamin D fat-soluble vitamins. Okay. And primary hypophosphatemia, not common condition, X-linked hypophosphatemic rickets is going to be the result. Okay, but we are not going to enter into details about that because that's very, very, very rare condition. So vitamin D deficiency, okay, that maybe due to dietary problems, okay, hypophosphatemia, some cases, chronic kidney disease may also have this as one of the results because we don't activate, okay, the vitamin kidney disease. Remember what we mentioned before, acidosis, calcium, the free calcium, okay, may increase because calcium separates from albumin. There are medications, for example, bisphosphonates, aluminum fluoride, that inhibit the bone mineralization. Okay, and this mineralization will make the bones very weak and will impair the growth of kids. Now, notice that here we have some pathogenic mechanisms. Okay, one or several factors that decrease the vitamin D production, all of these metabolic steps, lack of sunlight exposure, okay, and synthesis, generally in cold weather, but it doesn't matter where you live. If we are not exposed to sunlight, okay, the cold weather doesn't mean anything for this, okay. Maybe we live here in Miami, but we are all the time inside the house. And if we go out, we go directly to the car and from the car to some place, and we are never exposed to the sun. Okay, people with darker skin, melanin blocks the absorption of UV light. In the case of obesity, okay, obesity increases the sequestration of lipids in the adipose tissue. Okay, so we are going to have less calcidiol, okay, available for activation. So we have vitamin, but we don't activate it. With age, vitamin D decreases, the production decreases, storage declines. Now, decreased absorption, okay, nutritional deficiencies. Doesn't matter how much sunlight you take. If we don't take supplements, it's not going to be enough with the sunlight exposure. And different malabsorptive syndromes, celiac disease, Crohn's disease, cystic fibrosis, okay, for example, cholestasis, we don't produce the bile, or pancreatic insufficiency, okay, different conditions that affect the absorption or the intake. Now, there are these conditions that alter the vitamin D metabolism. Okay. In the case of chronic kidney disease, we have loss of the enzyme that activates vitamin D. And this enzyme may also be suppressed by hyperphosphatemia. When phosphate is too elevated, that may suppress alpha-1 hydroxylase. In people with nephrotic syndrome is a condition in which the kidneys let many things escape. Albumin goes to the urine, immunoglobulins go to the urine, HDL cholesterol goes to the urine, okay, and many other proteins. Okay, nephrotic syndrome is characterized by a huge proteinuria. More than 3.5 grams of protein per day are lost in the urine. Okay, so we may eliminate the vitamin D binding protein. Remember, this is a steroid hormone. Steroids need a protein to transport them. They are bound to proteins. Like we have the androgen binding protein, like we have different thyroid binding protein, there is a vitamin D binding protein. So if we eliminate this, okay, we are going to have low levels of vitamin D. People with liver disease, cirrhosis, okay, non-alcoholic fatty liver disease, or NASH, non-alcoholic steatohepatitis, we are going to have a liver is not working, so we are going to have a deficiency of 25-hydroxy vitamin D. Okay, so we don't have this. Pregnancy, what about pregnancy? Well, there is a lot of debate about what is normal in pregnancy, what is not, if we should treat everything, if we shouldn't. Okay, there are low levels of calcidiol. Okay, so some supplements are not going to hurt them. Okay, in pregnant women. Now we have more things about the pathogenesis of this hypo deficiency of vitamin D. Okay, notice how many things. It's not just the intake of vitamin D or taking sunlight. Okay, there are syndromes, in hereditary syndromes, that alter the metabolism of vitamin D. We have a condition known as renal tubular acidosis. We're going to be talking more about this in nephrology. Okay, there is one of the syndromes that produce renal tubular acidosis is called Fanconi syndrome, that alters the absorption, excretion of some ions. Okay, osteomalacia can be induced by cancers, tumor-induced osteomalacia, or oncogenic osteomalacia is rare. It's a paraneoplastic syndrome that is not very common. Okay, there is hypophosphatemia. Okay, may be produced by benign tumors or may be produced by cancers. And here we have some medications, anti-epileptic, antifungal medications, and some steroids, long-term steroid use. Okay, examples of anti-epileptic, phenobarbital, phenytoin, carbamazepine, that enhance the catabolism of calcidiol, inducing the P450. So we eliminate calcidiol, so we don't have enough to activate. Okay, other examples are isoniazid, rifampin, theophylline. Antifungals, okay, there is a different mechanism. Okay, these are ketoconazole, for example, increases the vitamin D requirement because it inhibits the alpha-1 hydroxylase, the enzyme that activates it. These are very important points, okay, to remember for the pharmacology when you don't use this medication. And long-term steroid, okay, increasing the 25, not the 24, 25 hydroxylase activity. Now, these are the symptoms that people may have. Weak bones, okay, so bone pain, joint pain, they may have fractures, pathological fractures or fracture with minor trauma. Muscle weakness, remember calcium is necessary for the muscle contraction. Difficulty walking. In kids, we have very characteristic findings. When they have rickets, bowed legs, the rachitic rosary line, which occurs as a result of the thickening of the costochondral cartilage. Okay, we are going to see a picture later. There is a sign that is called Harrison's groove, a depression along the diaphragmatic insertion into the rib cage. The diaphragm pulls from the ribs, and since they are soft, we are going to see a depression, okay, made by the diaphragm pulling from them. Kyphosis, lordosis, scoliosis, poor growth. In adults, we don't have these characteristic findings of rickets, but we may find bone tenderness to palpation. Okay, notice the rachitic rosary here, thickening of the, okay, the cartilages, okay, the costochondral cartilages. Okay, scoliosis, kyphosis, lordosis, bowed legs. And we mentioned this before. This is a condition that is very mild. Okay, it's autosomal dominant. Okay, people have a long-standing mild hypercalcemia, but normal PTH. And low calcium in the urine. And there is a mutation that inactivates the calcium sensing receptor. So calcium is elevated and the parathyroid glands don't do anything to lower it. Okay, they have no symptoms. Okay, it's a benign process. Okay, let's have a break. Okay, it is 11:50. Okay, let's have a break until 12:05. Okay, to continue with the hypoparathyroidism part. Any questions before going to the break? Okay, if you have any questions, just write it in the chat. Okay, let's move to the next part. We are going to be talking now about hypoparathyroidism. Okay, and here the main thing is to try to understand the relationships between different factors. Yes?
I'm sorry to interrupt. We can't see the slide.
Oh, sorry. I have to.
No problem.
Can you see it now?
Yes.
Oh, okay, perfect. Too many different things here. Thank you.
Hey, Professor.
Yes. Yes?
Yeah, I had a question on the chat. I'm not sure if you had a chance
okay,
to
no,
see it.
I didn't see. Oh, the difference between osteoporosis and osteomalacia. Well, osteomalacia is as the definition says, is a deficiency in the mineralization of the osteoid. So we don't add the calcium phosphate, the hydroxyapatite to the osteoid, so it remains soft. Okay, in the osteoporosis is when there is excessive resorption compared to the deposition or formation of new bone. So in osteoporosis, there is an imbalance between resorption and formation. There is an uncoupling of these resorption formation bone in the bone, while osteomalacia is no mineralization. So it stays soft, more collagenous, more, okay?
Thank you.
Okay, you're welcome. Okay, so in hypoparathyroidism, okay, we are gonna have the contrary, okay? There is a low PTH. Okay, this is a condition that is more common in older than 45, 70% of them are females. And one of the main causes, the most frequent causes, is the surgical removal of the parathyroid glands. Okay, so every time someone has a thyroid surgery, the parathyroids are removed. Typically, they take the parathyroids, one or two of them, and they implant under the skin, for example, in the forearm, hoping that they continue working there. Okay, generally they do, but in some cases they may not work. Okay, so they are going to have hypoparathyroidism. There are other conditions, the Cushing Syndrome, okay, in which the parathyroid glands are not formed, okay, or other genetic disorders, not as frequent. And remember, we have to consider when we have a problem with the parathyroid calcium regulation, the levels of magnesium. Okay, when there is hypomagnesemia, the parathyroid gland can secrete PTH. So we have to replace, okay, the magnesium. Okay, we have to consider hypomagnesemia as the cause in patients with alcoholism, nutritional disorders, malabsorptive disorders, people who are receiving chemotherapy, some medications. Because in a healthy patient, someone who doesn't have any risk factor for hypomagnesemia, it is very difficult to assess the magnesium levels. Magnesium is a mineral that is intracellular. Okay, so the serum calcium of magnesium actually don't tell us much about how is the magnesium in the body, because most of it is inside the cells. Okay, so the patient has to have demonstrated low magnesium levels, okay, repeated, not because of one day magnesium was low, demonstrated magnesium in the serum low, and also an explanation for that. Okay, malabsorption, malnutrition, alcoholism. Classically, in vignettes, what you have is alcoholism as the cause of hypomagnesemia. So what happens when there is low PTH? People are going to have low calcium levels and elevated phosphate. Okay, remember, the main action of PTH is to increase calcium and lower phosphate. We are going to have the contrary here. And the symptoms, findings that they are going to have are those produced by the hypocalcemia. That, I will repeat this, they may appear also temporarily when patients have alkalosis. Okay, hyperventilation, respiratory alkalosis, or any kind of metabolic alkalosis as well. Now, phosphate, when phosphate is elevated, okay, as a result of the low PTH or any other reason, will inhibit the activation of vitamin D. So that is going to lower the calcium absorption, making the condition worse. Okay, there is a primary hypoparathyroidism, surgical removal of the glands, the George, and a secondary hypoparathyroidism, which is simply the response of the parathyroid gland to anything that produces hypercalcemia. Okay, so that is actually a compensatory mechanism, physiologic mechanism, rather than a disease itself. Okay, low PTH in response to high calcium. And this is good to see because remember, if we go back to this table here, in none of these, you have low PTH. Physiological conditions will lower the PTH when calcium is elevated. Okay, when calcium normalizes, PTH normalizes. So this secondary hypoparathyroidism is more a physiologic response rather than a disease. For hypocalcemia, remember the findings on the physical exam. We may have these chopstick or Trousseau signs. Okay, severe hypocalcemia will produce tetany. Okay, people may have paresthesia. Okay, if you provoke the respiratory alkalosis, if we start voluntarily hyperventilating, we are going to feel this paresthesia around the lips, in the fingers, in the hands. We may feel the paresthesia. Okay, calcium, when it's low, may produce irritability, mood swings. Okay, we may see, for example, besides the Trousseau and chopstick signs, we may see tongue fasciculations. We may see laryngeal spasms producing changes in the voice. Okay, or may produce stridor if is an important spasm. Okay, wheezing, for example. And we may see in a longer, more chronic hypocalcemia, dry skin, loss of body, scalp hair, horizontal ridges in the nail. In the nails, of course, this is sustained for a long time. Okay, we may see cataracts, we may see calcifications in some basal ganglia. Okay, some bone deformities. Okay, and this is simply telling you what worsens. If someone has hypocalcemia and they start hyperventilating, of course, this is gonna get a lot worse. Now, osteoporosis. Osteoporosis is another metabolic disorder, okay, that in the past, we didn't know much about osteoporosis. The explanation in the past was people get old and the bones lose the calcium and they develop fractures. And we thought, okay, simply giving calcium and vitamin D, that's gonna get better. Well, that doesn't get better by giving calcium and vitamin D. Maybe we delay the progression, but it's not reversed. In of the calcium that we are going to have in the bones forever, okay, after the age of 25 or so, our bones start losing more calcium than the one that we can reincorporate to it. Okay, it's a metabolic disease in which there is a low bone density, okay, and destruction of the microarchitectural structure of the bone, leading to increased fragility and, of course, susceptibility to fractures in different places. The most common places are the vertebrae, wrists, hips. And there are two types. Type 1 is postmenopausal, and the type 2 is the senile, okay, in older people. Postmenopausal, of course, is the one that affects women. The type 2 may affect anyone, males, females. Okay, we are going to see the interaction between osteocytes, osteoblasts, osteoclasts in the pathogenesis of this condition. There is a cycle, okay, that occurs in our bones, is occurring all the time. That is the bone remodeling. Okay, when you study the anatomy of the bones, if you study this from the very beginning of life, you know that in the fetal life, okay, and very early in life, for example, during growth, we have the bone formation, bone modeling. Okay, we have a cartilage, for example, in the growth plate that we use as a model to create the bone. Now, after the bone is formed, okay, solid, we start having several cycles of bone remodeling, okay, that will occur with different frequencies in different bones of the body. For example, in the distal femur, okay, we have a total change of the bone, okay, at least once per year. Okay, depending on the physical activity, we may have it even more frequent. Okay, what is the bone remodeling cycle? Okay, we can start here on top. Okay, this is a bone, healthy bone. There you have an osteocyte, okay, that has these extensions that are like monitoring that everything is fine. Okay, we may have some microscopic fractures as a result of running, exercise, trauma, microtrauma. And those osteocytes are going to produce signals. And these signals are going to attract osteoclasts. Okay, let me do some annotations here. This osteocyte, okay, is going to produce a signal. We are gonna call it rank ligand. Okay, rank ligand is gonna stimulate the osteoclast precursor. But remember, are very similar to the monocytes. They are actually monocytes. Okay, rank ligand is gonna bind to the receptor in the osteoclast. Okay, many of these monocytes are gonna bind together, forming a multinucleated cell. That is the actual active osteoclast that will start the bone resorption, liberating calcium into the blood. Okay, opening or destroying all the tissue that has been damaged. Okay, that will be replaced later. Okay, then we have another phase here that is called reversal phase. We stop the activity of the osteoclasts. That is how they are like dying there. And then we are going to have the osteoblasts taking care, the osteoblast, taking care of repairing the bone there, forming the new matrix, laying down collagen, minerals. Okay. Typically, the activity of the osteoclasts lasts like 3 weeks. Okay, removing all this old bone takes like 3 weeks. And this activity is like 3 months. Okay, it takes a lot of time to repair that. But it's a process that is perfectly coupled. Okay, it's very well orchestrated, because all of this is under the control of different hormones. Okay, for example, PTH stimulates this. Vitamin D2 stimulates increased bone resorption. Okay, but if we have excessive resorption, there is a break. Okay, there is a break that is called osteoprotegerine. Osteoprotegerine is the break on this. So this doesn't reabsorb too much, and this doesn't extend beyond the 3 weeks, giving time to the repair. Osteoprotegerine is produced by the osteoblasts too, osteocytes, osteoblasts. Okay, it's the only thing that protects the bone. And for us to produce osteoprotegerine, we need the intervention of estrogen. Estrogen stimulates osteoprotegerine. That's why when we don't have estrogen, osteoprotegerine is not going to be produced. And these guys here, these osteoclasts, are going to work like crazy without stop. And we are not going to have time to repair what was destroyed before. Okay, and there are some conditions that even increase this here more, because this also can be stimulated by tumor necrosis factor, interleukin-1, interleukin-6. So chronic inflammation will accelerate the bone destruction. Notice how many factors destroy bone: inflammation, PTH, vitamin D. And only one factor stops the destruction: osteoprotegerine, OPG, that needs estrogen. Okay, you have here the same process. Okay, explained in a linear way. Here you have a cycle. Okay, this cycle here, okay, is called the formation or the destruction. Destruction doesn't sound good. Resorption, formation, coupling, also known as osteoclast-osteoblast coupling activity. When there is uncoupling, then we are going to have excessive resorption, leading to osteoporosis. Okay, it's a condition that is more common in females for the reason that we explained before. Okay, we are going to see a diagram later that shows you the rapid decline of in the level of estrogen in females after menopause. So anything that produces estrogen deficiency, menopause, age, okay, with inadequate intake of calcium vitamin D early in life. Okay. Family history, lack of physical activity. For example, weight-bearing exercises that stimulates the formation of new bone. Okay, if we have destruction of bone and we don't have physical activity, our body says, why do I need to make more bone if I'm not using this joint? Okay, the physical activity, the stress on the bone, on the joints, on these bones stimulates the osteoblasts to make new bone. So we repair more quickly. Okay, other factors, smoking, alcohol, corticosteroids. Okay, corticosteroids inhibit the production of osteoporoterene steroids. Okay, lithium is everywhere. Okay, you see that I'm not lying when I say that lithium is in every list. Okay, shouldn't they forbid lithium? They should ban lithium. Is responsible for everything. And other things, warfarin, PPIs. PPIs, many people try to blame PPIs for everything, okay? But this is not very demonstrated. What happens is that maybe the absorption of calcium is not very good when PPIs, but PPIs don't produce osteoporosis, okay? May decrease the absorption of calcium, but there are other ways. Low weight, low body mass index, more typical in Caucasians and Asians than in Blacks, for example. Okay, different conditions that increase PTH, hyperparathyroidism, hyperthyroidism because of the accelerated metabolism, multiple myeloma or any condition that damages the bone or the bone marrow, and chronic inflammation in general because of this tumor necrosis factor, okay, and other inflammatory cytokines. So remember, it's a metabolic skeletal disease, okay? This is exactly, again, what we mentioned before. The only thing new here is the prolonged imbalance in bone remodeling, okay? And this is an extremely important piece of information. If we are 50-year-old, we can't start taking calcium to increase our bone mass. That's not gonna work, okay? At least not clinically significant. It's like being, I don't know, 70-year-old and start saving for retirement when you are 70. No, that's something that you have to start doing when you are 30 or when you are 40, you know, okay? Aging is a problem, okay, for many things. There is a gradual decrease in calcitonin, increase in PTH as a result of the hypercalcemia, okay? And menopause leads to this decrease in estrogen. Notice this point here. This gray line here is representing a male, okay? This is the bone mass. Notice how the bone mass decreases, but very slowly in males. Okay, in the case of females, during menopause, there is a sharp decline because of the lack of estrogen. Now, notice that here, at this point, we have the peak bone mass. Okay, this is the average male or the average female. But imagine a female or a male that had a nutritional problem, okay, during early life. And for this person, the peak bone mass is here instead of there. Okay, what is going to happen when they reach the menopause? Notice this. Okay, so when they are at this point here, they don't have bone practically. Okay, so in that case, the osteoporosis is going to be a lot worse, okay, than for people who achieved a good bone mass when they had to. Okay. So the final thing that happens in osteoporosis is this destruction of the bone architecture that affects every part of the bone. Okay, the cortical bone, okay, affects the periosteal bone, cortical bone, and also the inner parts of the bone. Okay, there is an increased number in remodeling units. Okay, the resorbing cavities are too large. Remember, they don't have the brake. The brake is off. They don't have the osteoprotegerene, so too much destruction, too large cavities, too many. And now the formation of new bone is incomplete. Okay, and probably when they are building up new bone, we have new destruction of bone here. So there is no time, okay, to repair the bone. Okay, loss of bone leading to fragility. And well, we were mentioning this before. Okay, we reached this point and you already know what you have to know. Okay, we have here the osteoclasts destroying in that direction, and we have the osteoblasts behind them repairing the damage. Okay, this is the coupling activity between osteoclasts and osteoblasts. Notice the rank ligand stimulating the osteoclasts to destroy so they can come after them to repair and form new bone. Okay, we have here the precursors of the osteoclasts. Notice that there are several factors that stimulate them to destroy bone. The rank ligand, tumor necrosis factor, transforming growth factor, interleukins, monocyte colony stimulating factor, monocyte colony. After they finish, they have to be destroyed, the reversal, apoptosis of the osteoclast. If we don't do this, they are going to continue destroying bone. And notice estrogen serve as a brake, okay, for these inflammatory cytokines, okay, and it blocks the action of rank ligand on the rank receptor. It's not, remember, estrogen directly. We have estrogens, remember, stimulate OPG, osteoprotegerene. But there is a step missing there. They try to simplify this too much. Okay, in the next slide, we have the action, okay, of OPG, osteoprotegerene. Okay, this is little stars represent the rank ligand, okay, from the osteoblasts or osteocytes stimulating the precursors of the osteoclasts to become an active osteoclast. Okay, rank means rank receptor. Okay, the rank has to bind to the rank receptor there for it to happen. What is the action of osteoprotegerene? Osteoprotegerene is actually an antibody, an immunoglobulin that blocks or interacts with rank ligand so it doesn't bind to the receptor. Okay. All of this is going to be very useful when you study the treatment, the novel treatments for osteoporosis, stimulating the production of OPG, blocking rank ligand. So if they don't produce OPG, well, we are going to give monoclonal antibodies that will block the rank ligand to try to do what OPG should be doing. Okay, any questions about calcium and these conditions before going to adrenals? Remember, if you have any questions, write it there. If I don't see it, just let me know, because if the questions move, I don't see them. My goodness. Well, in the adrenals, before starting the adrenals, it's important to remember the normal structures in the adrenal glands. Okay, there is a cortex that produces steroids. That's why we call them corticosteroids. And the medulla that produces catecholamines. So epinephrine and norepinephrine. Okay, there you have a representation of the different layers of the adrenal cortex. And here, down here is the medulla. Okay, there are 3 zones, okay, from the periphery to the center. We have the zona glomerulosa, the zona fasciculata, and the zona reticularis. Notice that this is GFR, like in glomerular filtration rate. Okay, the zona glomerulosa, the outer layer, produces a mineralocorticoid. Aldosterone, regulated by renin-angiotensin. The zona fasciculata produces cortisol, which is a glucocorticoid. Glucocorticoid. And the reticularis produces the hydroepiandrostenedione. Okay, so androgens. A weak androgen. Okay, the aldosterone regulates sodium, cortisol sugar levels when we are fasting, and androgens perform several functions. This is more important in females, is the only source of androgens for females. And the medulla receives fibers from the sympathetic nervous system and produces norepi that has to be transformed to epinephrine. Okay. ACTH regulates cortisol and androgens, while renin-angiotensin system regulates aldosterone. Norepi has to be converted to epi, and that step there needs cortisol. So cortisol is going to come from here to help the production of epinephrine. It's necessary. In the stress response, cortisol is going to be released, and cortisol is going to go to the medulla, and it's going to help accelerate the production of epinephrine from norepinephrine. So everything is interrelated. We are going to see what happens to patients when they have excess or deficiency of cortisol or aldosterone. Okay. And also we are going to see, for example, pheochromocytoma, what happens when there is excess, how we interpret this. We are going to see Cushing syndrome. Okay, you are already very familiar with the signs and symptoms of Cushing. Okay, Cushing syndrome is simply the set of signs and symptoms that appear when people have excess cortisol, hypercortisolism. Okay, of course, to diagnose Cushing, first of all, we have to think on it. Okay, we have to document it, and then we have to determine the cause. Okay, it's a process. Saying that someone has Cushing syndrome actually doesn't tell us what the patient has. Okay, we have to determine the cause. Okay, and also be aware that some people may have elevated cortisol, may have little clinical manifestations that resemble Cushing, but maybe it's not Cushing syndrome. Okay, it's something that we call pseudo-Cushing. Okay, we are going to see some examples of situations that may lead to this. Now, what are examples of condition that produces pseudo-Cushing with some clinical manifestations? Pregnancy, people with severe obesity, especially if they have polycystic ovary syndrome. Okay, people with major depression, people with poorly controlled diabetes, rarely people with chronic alcoholism. That's not frequent at all. And people during physical stress or hospitalization, surgery, malnutrition, anorexia nervosa, intense exercise may have elevated cortisol, so pseudo-Cushing, with no clinical findings. We don't see the signs and symptoms of Cushing syndrome. And how we determine the etiology once we say the patient has elevated cortisol. Okay, for example, by looking at a 24-hour urine cortisol levels, okay, or looking at the cortisol in the saliva at night or in the late evening, and should be very low. Okay, when we have determined that the patient actually has hypercortisolism, we have to look at the cause. Okay, and we divide Cushing into ACTH dependent, that means elevated ACTH, or ACTH independent, low ACTH. Okay, if ACTH is elevated, okay, we have to consider different conditions. One of them is Cushing disease. We already mentioned the first day. Okay, pituitary hypersecretion, pituitary adenoma producing ACTH. Okay, this is the second most common cause overall. Okay, but it's the most common endogenous cause, the most common cause of endogenous hypercortisolism. And then we have to consider ectopic ACTH. Okay, pituitary, non-pituitary tumors, small cell lung cancer. Okay, and for that you can do the famous low dose or high dose prednisone suppression test. Okay, you can give the prednisone at night and assess the cortisol levels in the morning, okay, to see if there is a suppression of cortisol. If there is suppression, okay, we suspect this is Cushing disease. If there is no suppression, that is likely an ectopic secretion of ACTH. I'm creating some questions so you practice with this, so you can understand this better. Now, what about ACTH independent? Here we have the most common cause overall of hypercortisolism: exogenous, iatrogenic, patients in treatment with corticosteroids or factitious. They may be taking them and they don't tell anyone. Okay, and then we have some, for example, adrenocortical adenoma or carcinoma, okay, bilateral adrenal hyperplasia, macronodular. Okay, we are not going to confuse this bilateral macronodular adrenal hyperplasia with another condition that is called congenital adrenal hyperplasia, okay, that we are going to be seeing, okay, later or next time we meet. Okay, the signs and symptoms, very classic. You already have seen these many times. We also mentioned them the other day. It's very easy to recognize a vignette with a patient with Cushing syndrome. Okay, the truncal obesity with wasting in the arms and legs. Because remember, cortisol is a hormone that appears during stress, okay, to take amino acids and convert them to glucose. Okay, this is a process that we know as neoglucogenesis or gluconeogenesis. Gluconeogenesis, formation of new glucose. This is very important when we are fasting. But if we have elevated cortisol for a very long time, the amino acids from the muscles are going to be converted to glucose. So people have muscle wasting, muscle weakness, and hyperglycemia. Cortisol is going to increase the production of epinephrine. So we are going to have hypertension as well. Okay, and many other things. Okay. Elevated cortisol will produce premature osteoporosis, okay, will produce problems in the wound healing, recurrent infections, because this is an anti-inflammatory hormone, and will produce accumulation of fat in places where it shouldn't accumulate. also will impair the production of collagen. That's why we have very thin skin, striae, and poor wound healing. Okay, notice this kid here, okay, before the disease and after, 4 months after the disease. So moon phases, again here. There's the accumulation of fat, okay, buffalo hump that we call. Okay, and then we have congenital adrenal hyperplasia. Okay, congenital adrenal hyperplasia. We don't know anyone with it, and we don't hear anyone talking about this on TV. We think that this is something that is very, very rare. It's not. It's something that is very frequent. Okay, CAH. Okay, also has the name of Adrenogenital Syndrome. Okay, and it's actually a group of conditions with totally different clinical manifestations, depending on what enzymatic defect the patients have. Okay, we are going to try to understand at least the basics because this topic is complex. There are several enzymes that may be deficient, okay, that we are born with not too much of it, not enough of it. For example, 21 hydroxylase deficiency, which is 90% of the cases. So that's the one that you have to focus on and study better. But there can be also deficiency of 11 hydroxylase. We are going to see what these enzymes do. Or 17 hydroxylase deficiency. Notice that 21 hydroxylase deficiency, okay, is what 90% of all, is prevalent in 1 out of 60 individuals in the general population. So every time you are in the presence of 60 people, there is one that has this condition. Okay, if they are Ashkenazi Jews, so Jews from Eastern Europe or Russia, 1 in 3. If you go to New York City, 1 in 7 people there have certain degree of this condition. Okay, we don't know. They don't look like they have anything because there are different forms. There are very mild forms and there are very severe forms of the condition. For example, 21 hydroxylase, okay, is a condition that has different types of presentations, and it depends on if they are males or females. Okay, we are going to see the why of these things in the next slide. Okay, this condition presents with elevated androgens, okay, resulting in ambiguous genitalia in females and a precocious puberty in both sexes. Okay, and they have elevated levels of something called 17-hydroxyprogesterone. This is something that we use for the diagnosis. And besides the elevated androgens, they're going to have low cortisol, low aldosterone. Low cortisol is going to produce hypoglycemia. And the low aldosterone is going to produce hypotension. And they're going to have increased ACTH. Increased ACTH is going to produce hyperpigmentation. Okay, of course, not every patient will have all these. Okay, these are the main findings, okay, of this condition. But the condition can present as 2 forms, the classical and the non-classical. Okay, notice that the one that is more prevalent, okay, is the non-classical. Okay, can be diagnosed during adulthood. Okay, not during childhood. But the classical, this divided into salt wasting and non-salt wasting. depending on if they have problems with aldosterone or not. Okay, if they have a hyponatremic hypotension shortly after birth, they have the classical salt wasting form. It's more common in males. And then we have the non-salt wasting. They don't have this problem with aldosterone. Okay, notice that females are diagnosed early during the neonatal period and males in childhood. Why is that? Because of the ambiguous genitalia. When they are born, they have ambiguous genitalia. And of course, we have screening for newborns for this condition, and we diagnose them, okay, very early. But not for males. Males with the non-salt wasting may be diagnosed in childhood when they have precocious puberty. Now, why all these findings? Well, let's take a look at this. Okay, this is the pathway of production of the corticosteroids. Notice that here we have cholesterol, the precursor. Here we have aldosterone. Here we have cortisol. And here we have androgens. Okay, the androgens. Okay, what happens with cholesterol? Well, the first step is going to be converted to this substance, pregnenolone, that can take this pathway or this pathway. Okay, the pathway of the androgens or the pathway of aldosterone, okay, or the pathway of cortisol. Okay, if someone has 21 hydroxylase deficiency, okay, to understand what happens, you simply have to look for where is the enzyme in this diagram. Notice that the 21 hydroxylase is here and here. So when cholesterol is converted to pregnenolone and to progesterone, or to 17-hydroxyprogesterone, the metabolism stops there. And all these compounds are going to be converted to androgens. That's why people with 21 hydroxylase deficiency have high androgens and low cortisol and low aldosterone. Okay, what about if someone has a deficiency in 17 hydroxyprogesterone? Well, what they are not going to produce is androgens. Okay, but they are going to produce, okay, aldosterone, cortisol. What if they have deficiency of the 11 hydroxylase? Well, the 11 hydroxylase, okay, is here. They are not going to produce aldosterone or cortisol. They are going to produce androgens. Okay, but there is going to be a difference between 21 and 11. Okay, they will have excess of this deoxycorticosterone that has mineralocorticoid activity, so they are going to have hypertension because this works more or less like aldosterone. Okay, so in 21 hydroxylase, women are going to have ambiguous genitalia at birth, hypotension, hypoglycemia. When someone has deficiency of the 17 hydroxylase, since they don't produce androgens, both sexes are going to have delayed puberty. And here, the ambiguity of the genitalia is going to be for males, not for females. Okay, remember the default, okay, phenotypic sex is the female one. And we need the action of androgens to convert that default phenotypic genitalia into the male genitalia. If there is not enough amount of androgens, the genitalia are not going to develop completely as male genitalia. If there is excess, the female genitalia is going to develop almost like a male genitalia. Okay. So this is the basic of this. Okay, there is, following this slide, Okay, the pathogenesis of 21 hydroxylase deficiency from Calgary guides. Okay. And there are some pictures. For example, these are female ambiguous genitalia, 46XX with mild virilization, 21 hydroxylase deficiency. And in this case, on the right, severe virilization is XX karyotype. Okay, also for the same reason. Okay, and the next picture is it's a patient, okay, with congenital adrenal hyperplasia. Okay, compliance with medical therapy was poor, had early growth and skeletal maturation. Remember, they have excess androgens. Okay, when we have excess androgens, androgens stimulate growth, the linear growth, but they grow quickly, but they stop growing very fast. Okay, notice that this guy has the height is below that of the mother, final adult height. So different findings we may see depending on what is the enzymatic problem, how mild or severe is, if they comply with treatment or not. Okay, and we are gonna stop here. Okay, when you study this, focus more on the 21 hydroxylase. Simply, we are gonna be using the 11 and the 17 for differential diagnosis. Okay, but focus on this. And these are the important details to make the differential diagnosis between these conditions. Any questions? You're welcome.